Gender-specific care is very important because if we reflect on where we are today scientifically, it's the era of the potential of the genome. It's the era of, quote unquote, the emergence of personalized medicine. And if we think about sex-specific or gender-specific care, and I just want to be clear, sex is who we are genetically. Women have two X chromosomes, men have an X and a Y. And gender is how we are responded to in society because of our sex. But if we think about this era of the potential of science, and we think about the fact that men and women are different biologically, you know, every cell has a sex, and that's the phrase that the Institute of Medicine coined. The potential for the development of science, as we think about sex differences, is just enormous. What it means when we think about sex differences in health and disease is that men and women differ in every aspect of health and disease, and the potential for discovery here is tremendous. Today, we only are at the very early stages of understanding what some of those differences are from a clinical standpoint, and we really have a long way to go before we fully understand the scientific base for some of those differences. So just to give you an example, if you look at a woman who has heart disease or blockages in her arteries or symptoms that make one think she might have blockages in her arteries, we know that those symptoms differ between men and women. Now that's a clinical observation. What we don't know is why we see those differences in symptoms. Then if you do testing in a man or a woman, the qualities of the test, the sensitivity and the specificity, the characteristics of the test differ between men and women. Certain tests are better in women than they are in men. And then very interestingly, when you actually look at the type of disease women have, so what their arteries actually look like, the arteries can look different. And what we begin to understand is that some of the gold standard tests that we've been using for many years that are based on the typical disease that men have may not function as well in women. And so we've had many years of women undergoing these tests and being told that they are actually fine. So today we're in a different place. We understand that there are some of these differences. Some of that knowledge is not as generalized and as widely understood as we need it. What we don't understand is biologically, why do we see those differences? So as you can see, there's this cycle between clinical observation, science, getting the word out, translation of that science to clinical care, and observation, once again, feeding more science. I wouldn't say that there are specific issues that are unique to women. What I would say is that there are issues that are either more prevalent in women that need to be focused on, and some risks that impact women differently. So for example, if you look at diabetes, for reasons that we don't fully understand, the impact of diabetes on women's heart health seems to be more profound than it is in men. So diabetes will wipe away some of the early protection women have against heart disease, but women will be more likely to die of cardiovascular disease. And then when you layer over that some differences in, for example, across racial and ethnic groups, you see some very stark differences, for example, in African American women compared with white women, with African American women having much higher rates of diabetes and also having much higher rates at a very early age of cardiovascular disease. Another major health problem is depression. Depression is more common in women, and it also seems as though depression may be more linked to the development of further events, further coronary events when women already have heart disease. So once again, differences in the prevalence of disease and then differences potentially in the impact on outcomes in women. There are some newer technologies in the area of cardiology that I think are very exciting for women. So for example, if we look at the fact that women are more likely to lay down plaque in their arteries in a way that it is diffusely laid down as opposed to there being a very discrete blockage in the artery that can be opened up, for example, with a stent. If women have that more diffuse disease more frequently, then it's hard to see with our traditional tests, which is a cardiac catheterization. Newer innovations with things like intravascular ultrasound that allow us to put a tiny ultrasound probe into the artery and look at the artery almost from the inside out. That is a very important development for women in particular. Not that every woman should have it, but for certain women, for example, who might have a positive stress test, they get in the catheterization lab, the traditional test is done and there's no answer, this might be the appropriate next step. Another exciting advancement is the use of small wires that measure flow throughout the artery. If women are more likely to have what we call microvascular disease in the tiny arteries, the small arteries coming off the big ones, once again, that you can't see with our gold standard tests, then once again, for certain women for whom the answer is not totally clear with traditional tests, this may be an option. And this is very important because it allows us to make a diagnosis in an important subpopulation of women. And quite frankly, I think by thinking about women and how they differ, it will help us look at all patients differently. And it's always my belief that by looking at women and looking at the science and translating that science into clinical care, we actually improve the health of everybody because we begin really thinking about what each and every individual needs appropriate to kind of the evidence.